So, okay, everyone. So we are live now. So I heartily welcome all of you to this session. So as we know, my name is Dr. Abdul Naseer. I'm a neuromicrobiologist. Have completed an MD microbiology, then DNB microbiology. Then I have done my fellowship in neuro infections from NIMHANS. That is all the infections related to the brain. And also I'm a national level microbiology faculty in DBMCI, and also I'm a faculty in eGurukul app. So with that, we are beginning our today's session without any delay. So as we know, today we are going to discuss about meningitis, especially bacterial meningitis. So meningitis, and especially we are discussing bacterial meningitis. Right? Just a second. I will use the mic. So when we talk about bacterial meningitis, first we need to know, sir, what do you mean by meningitis? So when we take the brain, right, when we take the brain, so the brain is having the coverings to protect the brain. And we know that there are 3 layers covering the brain. And these layers are nothing but meninges. And the outer layer is dura matter, the middle layer is arachnoid matter, and the inner layer is pia matter. These 3 coverings, they are known as meninges, right? And brain is known as brain. So the inflammation of meninges is known as meningitis. Very important. Inflammation of meninges is known as meningitis, whereas inflammation of brain is known as encephalitis. So this is the first difference what we need to know, the difference between the meningitis and encephalitis. So meningitis is the inflammation of the meninges, which are nothing but coverings of the brain, whereas encephalitis is nothing but the inflammation of brain parenchyma itself. Right? This is the difference between meningitis and encephalitis. And if you see somebody suffering from meningoencephalitis, that means both meninges are inflamed, both meninges and brain both are inflamed, then we call the condition as meningoencephalitis. So this is the first thing what we need to know, the difference between meningitis, encephalitis and meningoencephalitis. In meningitis, only meninges are involved. In encephalitis, only brain parenchyma is involved. And in meningoencephalitis, so both meninges and brain parenchyma is involved. This is the first thing. Now, second thing, right? Second thing, when we talk about meningitis now, okay, when we talk about meningitis, if you talk about just meningitis, so meningitis can be caused by bacteria. That is bacterial meningitis. Meningitis can be caused by viruses. That is viral meningitis. And meningitis can be caused by fungi, that is fungal meningitis, and meningitis can be caused by parasites, that is parasitic meningitis. So all the 4 types of organisms can cause meningitis. Okay, next thing. So we are now in today's class, we are discussing only the bacterial meningitis. So let's begin with bacterial actual topic, that is bacterial meningitis. If we talk about bacterial meningitis, that is the inflammation of the meninges by bacteria. We all know that, right? Now, so there are 2 types of bacterial meningitis. One is acute and second is chronic. One is acute and second is chronic. So acute disease or chronic disease, we know that this is based on the progression of the disease. If disease progresses very fast, then that is acute disease. If disease progresses very slow, then that is chronic disease. So acute bacterial meningitis and chronic bacterial meningitis. So shortly, bacterial meningitis, we can use BM, right? Acute BM means acute bacterial meningitis, chronic BM means chronic bacterial meningitis. So there are many bacteria which can cause acute bacterial meningitis, and there are many bacteria which can cause, there is only one bacteria which can cause chronic bacterial meningitis. Whatever, if we see the important organisms or important bacteria which causes bacterial meningitis, whether it is acute or chronic. So let's start with acute bacterial meningitis. We all know that, so the bacteria, they are mainly classified They are mainly classified into gram positive and gram negative based on gram stain. So the bacteria which appear violet in color after gram stain, those are gram positive bacteria, and the bacteria which appear pink in color after gram stain, those are known as gram negative bacteria. So this is how we can classify bacteria based on gram stain. Now, second important classification of bacteria is based on the shape of the bacteria. So if we take the shape of the bacteria, if we take the shape of the bacteria, so based on the shape of bacteria, further the bacteria are classified into two. Further, the bacteria, they are classified into two. The round-shaped bacteria known as cocci and the rod-shaped bacteria known as bacilli. So based on which, so gram-positive bacteria can be gram-positive cocci or gram-positive bacilli. Gram-negative bacteria can be gram-negative cocci or gram-negative bacilli. Right? So gram-positive cocci, because they are gram-positive, they are violet in color. Because they are cocci, they are round in shape. Gram-positive bacilli, because they are gram-positive, violet in color. Because they are bacilli, rod in shape. Now, if you talk about gram-negative, so because they are gram-negative, they are pink in color, and because they are cocci, they are round in shape. Because they are gram-negative, they are pink in color, and because they are bacilli, they are rod in shape. So bacteria can be either gram-positive cocci or gram-positive bacilli. It can be either gram-negative cocci or gram-negative bacilli. Now, which are the bacteria which causes acute bacterial meningitis? That is what we are discussing now. Like I said, there are many bacteria which can cause acute bacterial meningitis. But if we consider the important bacteria which causes bacterial meningitis, so gram-positive cocci, Streptococcus agalactiae. Streptococcus agalactiae. It is a gram-positive cocci which can cause acute bacterial meningitis. One more is Streptococcus pneumoniae. Streptococcus pneumoniae. So Streptococcus pneumoniae is also known as pneumococcus, and Streptococcus agalactiae is also known as group B Streptococcus. Group B Streptococcus. We know that Streptococcus are classified into 20 groups based on Lancet field classification based on the carbohydrate antigen present in the Streptococcus. Out of these 20 groups which are designated as group A, group B, group C, group D, only group A and group B can cause infections in humans. Out of that, group B is the one which can cause meningitis. So group B Streptococcus and Streptococcus pneumoniae, these are the two important gram-positive bacteria which can cause acute bacterial meningitis. Now if we talk about gram-positive bacilli, so Listeria monocytogenes. Listeria monocytogenes is the gram-positive bacilli, which important gram-positive bacilli which can cause meningitis. So these are the three important gram-positive bacteria. If we talk about gram-negative cocci, so gram-negative cocci which can cause bacterial meningitis is Neisseria meningitidis. Neisseria meningitidis, which is also known as meningococci. And if we talk about gram-negative bacilli, so the three important gram-negative bacilli which can cause acute bacterial meningitis, first one is Escherichia coli. Escherichia coli, that is E. coli. Second one is Klebsiella pneumoniae. And the third one is Haemophilus influenza. Haemophilus influenzae B, that is the serotype B. So these are the four important gram-negative bacteria which can cause acute bacterial meningitis. So 3 important gram-positive and 4 important gram-negative. Totally there are 7 important bacteria which can cause acute bacterial meningitis. If we talk about chronic bacterial meningitis, so there is only one important bacteria which can cause chronic bacterial meningitis, and that is Mycobacteria. That is Mycobacterium tuberculosis. So all the important etiological agents are there in front of you now which causes bacterial meningitis. acute and chronic. There are various bacteria which can cause acute bacterial meningitis. Important are these 7. Out of these 7, now we know which are the ones which are gram-positive cocci, which are the ones which are gram-positive bacilli, which are the ones which are gram-negative cocci, and which are the ones which are gram-negative bacilli. Then we also know the one bacteria which can cause chronic bacterial meningitis, that is Mycobacterium tuberculosis. Right? Okay, fine. Now let's start. So once we know the etiological agents, the next important thing is, so we know these are the bacteria which can cause bacterial meningitis. Now, how do they cause bacterial meningitis? What is the pathogenesis? How do they cause the disease, that is meningitis? That is nothing but pathogenesis. So if we talk about pathogenesis, it is very simple, sir. So one is direct spread. One is direct spread. And second is hematogenous spread. So what do you mean by this direct spread or hematogenous spread? If we talk about direct spread, so any local infections, for example, otitis media, middle ear infection. Somebody is suffering from middle ear infection. From that, the bacteria can go to the brain and can cause meningitis. Right? Direct spread from the local surrounding infections. And sinusitis, somebody is suffering from sinusitis. Right? The bacteria from the sinuses can spread to the brain and can cause meningitis. So local infections are local spread. Now that is the direct spread, one example. And second example is, sir, any surgery, that is iatrogenic infection. Iatrogenic means doctor induced, right? While using the instruments, if the instruments are not properly sterilized, at that time, if neurosurgery is going on, the bacteria, if it is there on the instruments, or it can enter into the brain, right? Iatrogenic during the surgery, right? They may enter into the brain due to if the instruments are not properly sterilized. The next important thing is, sir, any trauma due to road traffic accident or anything. So when the skull is damaged and the cranial cavity is opened and right to outside, so the organism may enter into the brain and then they can cause the meningitis. So these are the things by which, and yes, few bacteria may enter through the nose. Few bacteria may enter via nose. Through the nose, they can enter the olfactory nerve. From there, they can cross the cribriform plate and they can reach the brain. So these are the various modes of spread, direct spread by the bacteria, which may reach to brain and they can cause meningitis. Local infections, then surgery or iatrogenic cause direct spread, then trauma, then entry via nose, which crosses via olfactory nerve, crosses the cribriform plate and reaches the brain. Now, if we talk about the hematogenous spread, sir, any mode of transmission, whether inhalation or ingestion, whatever. So when the organism reaches the blood, that is into systemic circulation. Then from the blood, as blood goes to the brain to supply the brain, the organism via blood, it can reach the brain and it can cause meningitis. So via blood, it can reach the brain and cause inflammation and cause meningitis. So this is in short about pathogenesis. So the organism may reach the brain directly or via the blood route. Directly means due to any local infections or due to surgery or trauma or via nose. So from these areas, they directly enter into the brain, whereas hematogenous spread, whatever route they may enter, so ultimately they will reach the brain, blood. When they reach the blood, via blood, if they reach the brain, that is what we call it as hematogenous spread. Whatever, when they reach the site, that is the brain or meninges, so they cause inflammation and finally, which will lead to meningitis. So this is about pathogenesis. We know what is bacterial meningitis and which are the bacteria which causes bacterial meningitis, and we know how these bacteria, they reach the brain and they causes inflammation and they causes meningitis. Now we are moving on to the diagnosis. So very important thing, the important point in microbiology is nothing but diagnosis. So that's why what I'm telling, even though if NEET is replaced by next, even though if next is going to come, so all the pre and paraclinical subjects, they will retain their importance, because if you take any clinical subject, right? Whether medicine, surgery, even ENT, ophthalm, orthopedics, any clinical subject. So all the clinical subjects, they are nothing but we study nothing but we study diseases in all the clinical subjects. And when we take diseases, we know that, so there are mainly two types of diseases: infectious and non-infectious. Infectious diseases caused by organisms, again microbiology is important. Non-infectious diseases, we need to know pathogenesis, again pathology is important. Then ultimately, whatever may be the disease, we have to diagnose. Sir, infectious diseases are mainly diagnosed by microbiology. Non-infectious diseases are mainly diagnosed by pathology. Again, microbiology, pathology are important. Ultimately, whatever may be the disease, we have to treat. Treatment means pharmacology is important. So if you take any clinical subject, what I say is clinical subject is nothing but combination of especially microbiology, pathology, and pharmacology. Patho, micro, pharmac. The second year, three subjects are very, very important. You take any clinical subjects. That's why these three subjects are the core subjects, whether it is need or next. So anyways, with that, now diagnosis. Now we are talking about diagnosis. Sir, how are we going to diagnose? Yeah. How are we going to diagnose that patient is suffering from bacterial meningitis or not? If patient is suffering from bacterial meningitis, what is the causative agent? Which bacteria is causing the meningitis? First thing what we need to know is the clinical diagnosis. First diagnosis is based on clinical diagnosis, that is clinical manifestations, right? So based on the clinical manifestations, so there are two types of clinical manifestations we see. First type of clinical manifestations, it is two types of clinical manifestations we see. First type of clinical manifestations, it is due to, right, increase intracranial pressure. It is due to increase intracranial pressure, that is increase ICP. Whatever may be the disease, in few diseases, what happens in the brain is intracranial pressure may increase. So due to rise in intracranial pressure, right, the patient may have headache. The patient might have headache, vomiting, especially the vomiting is projectile vomiting, right? Projectile vomiting. And then the patient may have altered sensorium. And sometimes patient may have photophobia. Right? So these are the four important clinical manifestations which suggest there is an increase intracranial pressure, severe headache, projectile vomiting, altered sensorium, and sometimes photophobia. Obviously, because there is an inflammation, that is itis means inflammation, fever is the important clinical manifestation. There is no doubt in that. And then now the clinical signs which suggest that there is bacterial meningitis. So signs of meningeal irritation. So when there is inflammation to the meninges, we know that meninges are irritated. So the signs of meningeal irritation which says that patient is suffering from meningitis. The first important sign is the neck stiffness, neck rigidity or neck stiffness is the first important sign. When we ask the patient to flex the neck, when we ask the patient to touch the chest with the chin, patient is not able to touch the chest with the chin, and patient may feel pain when trying to do so. So that is due to neck stiffness. That is the very important sign of meningeal irritation. So second important sign is Kernick sign. Right? What is neck stiffness? Right? Difficulty in flexing the neck. Difficulty in flexion of neck. That is Kernick sign. Now what that is neck stiffness. Now what do you mean by Kernick sign? When the patient is lying, we need to flex the hip. Ask the patient to flex the hip. Hip is flexed, right? Along with the hip, knee is also flexed. So now we have to ask the patient to extend the knee. So difficulty in extension of knee. difficulty in extension of knee, difficulty or pain in the extension of knee, or inability to extend the knee fully when the hip is flexed, then that is what is known as Kernick sign, which is one more important sign of meningeal irritation. The third important sign is Brudzinski sign. What is Brudzinski sign? So Brudzinski sign is nothing but when we flex the neck of the patient, when we flex the neck of the patient involuntary flexion of hip and knee occurs. This is what is known as Brudzinski sign. So these are the three important signs. If these signs are positive, then we can say there is meningeal irritation and patient is suffering from meningitis, right? So there is one important thing what you need to know. There is no seizures, there is no epilepsy, because seizures and epilepsy is the clinical manifestation of encephalitis when brain is involved. So when brain parenchyma is involved, then only we see the seizures or epilepsy. Otherwise, in meningitis, there is no seizures or no epilepsy. Very important. So we see fever due to inflammation, and we see headache, projectile vomiting, altered sensorium, and photophobia due to increase in ICP, intracranial pressure. That happens in meningitis, but increase in ICP can happen in encephalitis also, and other forms of other diseases of CNS, that is central nervous system, increase ICP can happen. So this is not the characteristic of meningitis, but you can say it is the characteristic of any or some central nervous system diseases, increased ICP findings, headache, projectile vomiting, altered sensorium, and photophobia. But the signs of meningeal irritations are these three. If you demonstrate all these three or one of these three, then yes, we can say patient is suffering from meningitis. So by this clinical manifestations, we can say that patient is suffering from meningitis. So this is the first thing. Now second thing. So second thing, we know that patient is suffering from meningitis. What is the causative agent? Can we guess what is the causative agent? What might be the causative agent just by doing the clinical examination? Answer is yes, based on the age group. So based on the age group, if the patient is a neonate, or if the patient is a childhood, or if the patient is adult, or if the patient is elderly. So we are taking 4 age group of people: neonate, childhood, adult, and elderly. If the patient is a neonate, the most common bacteria which can cause bacterial meningitis, we remember with the universal mnemonic, that is Bell. Everybody remember with the same mnemonic, that is Bell. So B for group B streptococcus. That is nothing but Streptococcus A galactiae. Sir, E for Escherichia coli, that is nothing but E. coli, and L for Listeria monocytogenes. So if it is a neonate, we can think of only these three because these three are more common in a neonate. Now among these three, sir, more common or most common is group B Streptococcus, and second most common is Listeria. Nowadays, the Listeria cases are increasing in neonatal meningitis. There is no doubt in that. But still, group B Streptococcus remains the most common cause. In future, it may change, but at present, group B Streptococcus is the most common cause, and Listeria is the second most common cause. And nowadays, we are seeing a rise in cases of neonatal meningitis due to Listeria. So now, if we talk about childhood, adult, and elderly, sir, the organisms are same. The bacteria are same, which causes meningitis in childhood, adult, and elderly. But the most common organism in childhood which causes meningitis is Haemophilus influenzae B. Haemophilus influenzae B is the most common, right? Yes. Otherwise, the other organisms like Pneumococcus, Meningococcus, right, and Klebsiella can cause meningitis in childhood, but the most common remains Haemophilus influenzae in childhood, like 3 to 7 years of age. Now, if we talk about adult, sir, adult, the same 4 organism causes meningitis in adult, but the most common organism remains Pneumococcus. that is Streptococcus pneumoniae remains the most common organism. But yes, after that, meningococcus can also cause meningitis in adults. Haemophilus influenzae can also cause meningitis in adults, and Klebsiella can also cause meningitis in adults. But the most common is pneumococcus. Now, when we talk about elderly, so same like adult, there is no change. Pneumococcus remains the most common. And yes, the other three organisms like meningococcus can cause and Klebsiella can cause, but usually we don't see H. influenzae in elderly. Usually, right? So these are the most common organisms which causes meningitis at different age groups. So clinically, based on the age group, we can presumptively think the differential diagnosis or the causative agent. So this is the second thing. Based on clinically, based on the age group, how can we narrow down to the diagnosis, right? So now third important point in the clinical diagnosis. Now, once we see the clinical manifestations that patient is suffering from meningitis, increased ICP signs and meningeal irritation signs. So if we see the clinical manifestations of meningitis associated with skin rashes, and also the patient is showing the small red color petechial rashes all over the body. So bacterial meningitis associated with skin rashes, then presumptively we can say the organism is meningococci, because meningococci is the only bacteria which can cause meningitis which is associated with skin rashes. There are few viruses which can cause meningitis associated with skin rashes. There is no doubt in that. But if you talk about bacterial meningitis, only bacteria as positive agents of meningitis. Among the bacteria, meningococcus is the only bacteria which can cause meningitis which is associated with skin rashes. So this is how we get a clinical clue that patient is suffering from bacterial meningitis, and we can narrow down to the causative agent with the age group of the patient, and we can narrow down to the meningococci if it is associated with skin rashes. So this is the clinical diagnosis. So after clinical diagnosis, we have to confirm it by lab diagnosis. So when we talk about the lab diagnosis, the first thing what we need to know is the sample collection. What is the sample collected? As we all know, the CSF is the sample which is collected. And the most common method of CSF collection is lumbar puncture. That is introducing the needle in the lumbar area, especially L4, L5 or L3, L4. In between L3, L4, or we can also select L4 and L5. Patient should be in the lateral recumbent position. Patient should lie down and patient has to turn laterally, and then patient has to flex the hip and knee and also the body. So then the clinician will introduce the needle between L3, L4 or between L4, L5, right? Then we have the clinician will collect the CSF sample. CSF sample is collected by doing the lumbar puncture. So once the CSF sample is collected, the first thing what we do for lab diagnosis is CSF analysis. Very, very important. Right? CSF analysis can be done. Sir, what do we see in CSF analysis? First, let's talk about the parameters we see in the CSF, and what is the normal range of those parameters, and what happens to these parameters when there is bacterial meningitis. And what happens to these parameters when there is mycobacterial meningitis. Right? Mycobacterial meningitis. Nothing but I'm talking about acute meningitis and chronic meningitis. One thing I forgot to tell, sir, acute meningitis is also known as pyogenic meningitis. Very important point. Acute meningitis is also known as pyogenic meningitis. And usually we call acute meningitis as bacterial meningitis and chronic meningitis as mycobacterial meningitis. Right? And what happens to these parameters in other infections? Other infections means other infections like Other infections like viral meningitis, fungal meningitis, or parasitic meningitis. What happens to these parameters? Now let's talk about the first parameter. The first parameter is morphological appearance of CSF. Morphological appearance of CSF. If CSF is cloudy, right, whitish cloudy in appearance, or CSF is turbid, sorry, first we have to talk about the normal appearance of the CSF. So normal appearance of CSF is clear. CSF is clear. Normally the CSF is clear. But if the patient is suffering from bacterial meningitis, usually the appearance of the CSF is cloudy, right? Whitish cloudy like appearance, or the CSF will be turbid. If you see cloudy or turbid CSF, you can guess the patient is suffering from bacterial meningitis. If you see xanthochromic CSF, xanthochromic means straw colored, urine color, straw color or urine color CSF, then you can think of the patient might be suffering from mycobacterial meningitis. Then in other infections, usually, sir, the CSF is clear like normal. CSF is clear like normal. So based on the appearance, we'll get the clue whether it is bacterial, mycobacterial, or other, or normal. So now next, after the appearance, when we are collecting the CSF, so we measure the CSF pressure, right? We measure the CSF pressure, opening pressure of CSF, right? Opening pressure of CSF. When we talk about opening pressure of CSF, normal pressure is, sir, 100 to 180 millimeter of H2O. This is the normal CSF pressure in the lateral recumbent position. That is, in the lying position, the pressure is 100 to 180 millimeter of water. That is normal. Why I'm telling lateral lying down position? Because CSF pressure changes if you change the position. If the patient is standing, the normal pressure is somewhere between 200 to 300, the normal in standing position. So as we collect the CSF in the lying position, in the lateral recumbent position, in that position, right? In that position, the normal CSF pressure is 100 to 180 millimeter of water. So if it is bacterial infection, so the pressure is increased. If it is the bacterial infection, the pressure is increased. How much increased? It is very much high. In case of mycobacterial infection, it is moderately increased. In case of other infections like viral, fungal, or parasitic, the pressure is increased but slightly increased. So bacterial highly increased, then mycobacterial moderately increased, other infections slightly increased. So this is the opening pressure of CSF in various types of infections. The next important thing what we need to know is the cells which are present in the CSF. So usually CSF won't be having any cells. Usually CSF won't be having any cells, but still up to 0 to 5 cells. Up to 5 cells is considered as normal. 0 to 5. Like I said, usually CSF won't be having any cells, 0 cells. But if the cells are present up to 5, it is considered as normal. So if the cells are present up to 5, which we are considering it as normal, what type of cells which are present normally? So when you ask this question, the answer is lymphocytes which are present normally. Usually CSF is not having any cells. If it is present, up to 5 cells are considered as normal, more than 5 cells considered as abnormal, or there is any other cause. And those 5 cells which are present, those are lymphocytes. Lymphocytes. Now when we talk about bacterial infection, so cells are highly increased, and those increased cells are polymorphonuclear cells. Polymorphonuclear cells are nothing but neutrophils. So if you see very high increase of neutrophils in CSF, presence of neutrophils and very high increase in neutrophils, then they are present in very high number, in thousands, 100, 200, 1000, 3000, 5000, 10,000 cells, so many cells, then you can say, and that too neutrophils, then we can think of bacterial meningitis. So if the cells are increased but not very high, moderately increased, and those increased cells are lympho, then you can think of mycobacterial or other meningitis, that is viral, fungal, or parasitic. only change what we see in bacterial meningitis where neutrophils are increased. Otherwise, in all other forms of meningitis, lymphocytes are increased and moderately increased in lymphocytes. So they may be in 100, 200, 300, 400, up to 500, but not more than 500. Lymphocytes are there and moderately increased in cells. Whereas in bacterial meningitis, we won't see lymphocytes, we see neutrophils and very high increase in neutrophils, especially in 1000, 1000, 2000, 3000. So more than 500 usually. Sometimes you can see less than 500 also, but usually more than 500 we see. So this is about the cells. The next parameter is the glucose, CSF glucose. So if you see the CSF glucose, so normal glucose is 40 milligram per deciliter. So in CSF, glucose is present and normally it is 40 milligram per deciliter, right? 40 milligram per deciliter. In case of bacterial meningitis, glucose is decreased and it is drastically decreased. It is decreased. It will be less than 20 or less than 10. Less than 20 or less than 10. In mycobacterial, so it is decreased. Glucose is decreased, but moderately decreased. Overall, in bacterial infections, glucose is decreased, but in bacterial, highly decreased. In mycobacterial, moderately decreased. So what about other infection? It is decreased or it may remain normal. That is important. Now the last important parameter, there are many parameters, but these are the very important parameters for the entrance examination, right? For our university and entrance examination, 5 important parameters: appearance, opening pressure, cells, glucose and proteins. So when glucose decreases, exactly opposite with the proteins increases. The normal protein range is 50 into 45 milligram per deciliter. This is the normal range of proteins present in the CSF. In case of bacterial meningitis, proteins are elevated but slightly elevated. That's why I'm showing with only one arrow mark. But in mycobacterial, proteins are very much elevated, are highly elevated. So very important point which shows towards what mycobacterial, that is very high proteins, because very high proteins we won't see in bacterial meningitis and also we won't see in other forms of meningitis. In other forms of meningitis, proteins are slightly increased or they may remain normal, right? They remain normal. So now first we need to know how to differentiate bacterial and mycobacterial. So bacterial, cloudier, turbid appearance; mycobacterial, xanthochromic. In bacterial meningitis, opening pressure is highly increased. In mycobacterials, moderately increased. Whereas in bacterial meningitis, cells are highly increased and neutrophils. Here in mycobacterial, moderately increased and lymphocytes. So glucose highly decreased in bacterial, moderately decreased in mycobacterial. Proteins slightly elevated in bacterial, highly elevated in mycobacterial. So in other form of meningitis, you can see these parameters which are almost same. So this is how we'll come to a conclusion that with the CSF analysis, whether it is bacterial, mycobacterial or other type of or maybe other cause of this meningitis. So CSF analysis. So once we are done with the CSF analysis, so the next mode of lab diagnosis is microscopy. So we have got an idea with the CSF analysis, whether it is bacterial or mycobacterial, whether it is acute meningitis or chronic meningitis, whether it is pyogenic meningitis or mycobacterial meningitis. So we got the idea. Now let's move on to the microscopy. We know that the most commonly used staining technique for bacteria is gram stain or gram staining. As we have already discussed. So if we perform gram stain, so there are 4 possibilities. So we can see the bacteria violet in color, round in shape, or violet in color, rod in shape. Or we can see the bacteria which are pink in color, round in shape, and pink in color, rod in shape. So that is nothing but I'm talking about gram-positive cocci, gram-positive bacilli, gram-negative cocci, and gram-negative bacilli. First, by looking at the color and appearance, we'll get an idea and we can narrow down. So if it is gram-positive cocci, then we can think of Streptococcus agalactiae or Streptococcus pneumoniae, right? Or Streptococcus pneumoniae. And based on the age group, so if it is a neonate, then Streptococcus agalactiae. If it is adult or elderly, it is Streptococcus pneumoniae. This is how we can get a clue that whether the positive agent is Streptococcus agalactiae or pneumonia. We have to combine the clinical manifestations and also the laboratory findings. So now if you talk about, if you see gram-positive bacilli, then possibility is most common cause is Listeria monocytogenes. Listeria monocytogenes. Now, yeah, one more thing. So when we see gram-positive cocci, right, violet color cocci, then we can think of Streptococcus agalactiae or Streptococcus pneumoniae. Streptococcus agalactiae, Streptococcus pneumoniae. There is no doubt in that. No doubt in that. But if you see Streptococcus agalactiae, then in the gram stain, what we see, we know that Streptococcus are gram-positive cocci which are arranged in chains. If you see violet color cocci arranged in chains, again that will give a clue that it is Streptococcus agalactiae, and we know that pneumococcus is a gram-positive cocci which is arranged in pairs, right? So Streptococcus agalactiae is arranged in chains. It is arranged in chains, whereas pneumococcus, that is Streptococcus pneumoniae, is arranged in pairs. And if you see the individual cocci, it is lens shape or lanceolate shape, right? Lens shape or lanceolate shape. Then if we see, it is capsulated, the presence of capsule. So we can see a clear halo surrounding the cocci in the gram stain. Again, these findings, it will help us to identify, yes, the organism what we are seeing in microscopy is Streptococcus pneumonia. One is age group. Second, the arrangement of the cocci will also help us to come to the diagnosis, whether it is agalactiae or it is pneumococcus, that is Streptococcus pneumoniae. So when we see Listeria monocytogenes, we won't see any special arrangement. We see just the violet color rods. Now to confirm it is Listeria monocytogenes, what we can do is, sir, we can perform hanging drop. Right? To confirm it is Listeria monocytogenes, very simple is we can perform hanging drop. And if we perform hanging drop, we know that Listeria is motile at room temperature and it shows tumbling motility. If you see tumbling motility on hanging drop, then we can again think of Listeria. And you know, Listeria is motile only at room temperature, that is 25 degrees Celsius, where it shows tumbling motility. Whereas Listeria is non-motile at body temperature, that is at 37 degrees Celsius. It is non-motile. So this type of motility, motile at one temperature and non-motile at another temperature, is known as differential motility. Again, that we should not forget regarding Listeria. So Listeria shows differential motility. Sir, what do you mean by differential motility? Motile at one temperature and non-motile at another temperature. Listeria is motile at 25 degrees Celsius, that is room temperature, and non-motile at 37 degrees Celsius, that is body temperature. When it is motile at room temperature, it shows a special type of motility, a characteristic motility, and that is tumbling motility. So this will again help us to identify, yes, this is Listeria. Anyways, this is on microscopy. I'm telling microscopic findings which gives a provisional diagnosis by which we can identify what is the organism causing the disease. Now, if we talk about the gram-negative cocci, so the most important or most common organism is meningococcus. When we talk about meningococcus, sir, if you see pink color cocci, then we can think of meningococcus with the signs and symptoms of meningitis. When we are discussing meningitis, so if you see gram-negative cocci, then we have to think of meningococcus, because that is the gram-negative cocci which is the most common bacteria causing, most common gram-negative cocci causing meningitis. So we have to think of meningococcus. But still, what is the arrangement or microscopic findings to say it is meningococcus? We know that meningococcus is similar to pneumococcus. The meningococcus is also arranged in pairs. Meningococcus is also arranged in pairs. Second, meningococcus is also lens shaped, and meningococcus is also capsulated, right? We can see a halo-like structure surrounding the cocci. So see pneumococcus and meningococcus. So both are arranged in pairs, both are lens shaped, and both are capsulated. What is the difference? How can you differentiate pneumococcus and meningococcus? So pneumococcus is violet in color because gram-positive after gram stain, and meningococcus is pink in color. That's how you can say it is meningococcus and pneumococcus and meningococcus. And one more important thing, we know that meningococcus is facultative intracellular. That means most of the cocci, they are present within the cells and few may present outside the cell. So they are present within the cells and also outside the cells. Usually what we see is meningococcus present within the neutrophils. Neutrophils, you know that, which are having multi-lobe nucleus, 3 to 4 nuclei will be there. So this is a neutrophil or pus cell within which we are seeing the gram-negative cocci arranged in pairs, lens shape, capsulated. We can think of meningococcus, which causes meningitis. So facultative intracellular, that point is important. So meningococcus is a facultative intracellular. So these are the 2 points by which we can differentiate pneumococcus and meningococcus. What are the 2 points? Pneumococcus is gram positive, meningococcus is gram negative. Pneumococcus is extracellular, always extracellular, obligate extracellular, whereas meningococcus is facultative intracellular. We see within the pus cells, and also few of them will be present outside the pus cells. If we talk about the gram negative bacilli, the gram negative bacilli, you know that first one is E. coli or Escherichia coli. Right, second is Klebsiella pneumoniae, and third is Haemophilus influenzae, B. Right. So in general, though there are minute differences, and there are few minute differences, and we can guess whether it is E. coli or Klebsiella, Haemophilus, but not important for you people. But anyways, let's discuss E. coli, Klebsiella, and Haemophilus. Sir, all of them are gram negative bacilli. So that means all of them are rods, pink color rods. All of them are pink color rods. So E. coli is long pink color rods. If you see long pink color rods, you can think of E. coli. If you see short and stout pink color rods, you can think of Klebsiella. Right? Provisional diagnosis, just a guess or the clue. Then if we see gram negative Coccobacilli, right? So if you see Coccobacilli, because Haemophilus influenzae B is not bacilli, it is a Coccobacilli. So Coccobacilli means the organism is exactly not like cocci and exactly not like bacilli. It is somewhere between cocci and bacilli. So elliptical shape, usually elliptical. If you see Coccobacilli, then you can think of Haemophilus influenza. So long pink color rods in case of meningitis, because there are many other bacteria which are present as long pink color rods. If you see long pink color rods, you cannot say E. coli. But if the patient is suffering from meningitis, and if the patient is a neonate, because you know E. coli is most common in neonate, patient is a neonate manifesting the signs of meningitis, then if you see long flat pink color rods in the gram stain, then you can think of E. coli. Short, stout, and the patient is adult or elderly, Klebsiella pneumoniae. Child 3 to 7 years of age, Coccobacilli we are seeing, gram negative Coccobacilli, then we can think of Haemophilus influenza B. So these are the clues which help us to identify or to guess what is the organism in microscopy. Right? This is microscopic findings. So we are done with the CSF analysis and we are done with the microscopic findings. So once microscopy is done, the next important thing is culture findings. So we have to add the sample on the culture media, and we all know that for bacterial culture, we inoculate all the samples on 2 agar, that is blood agar and McConkey agar. So blood agar, and the first thing is blood agar and McConkey agar. So blood agar and McConkey agar, these are the 2 types of agar which are used for all types of bacteria. Now, first important thing what we need to know. So if the organism is growing only on blood agar, then we can suspect the organism is gram positive. If the organism is growing on both blood agar and McConkey agar, then we can say the organism is gram negative. Why? See, blood agar, I'm using the short terminology BA, McConkey agar, I'm using the short terminology MA. And you know that we always use the McConkey agar, McConkey agar containing bile salts. We always use the McConkey agar containing bile salts, and we know that bile salts inhibit gram positive. Therefore, only gram negative grows in McConkey agar. The McConkey agar which contains bile salts, only gram negative grow on that McConkey agar, because we use always that McConkey agar which contains bile salts, which inhibits gram positive, which allows only the growth of gram negative, right? So because of that, if the when we add the sample on blood agar and also on Macon Kygo, sample is added on both the agars, blood agar and Macon Kygo, and after that when we see the growth, organism has grown only on blood agar, not grown on Macon Kygo, then we can say so organism is gram positive. That's why growing only on blood agar, not growing on Macon Kygo, because on Macon Kygo only gram negative grows, gram positives are inhibited because of the presence of bile salt. Now, if the organism is growing on blood agar and also Macon Kygo, then you can say the organism is gram negative because it is growing on Macon Kygo. Because on blood agar, gram positive also grows and gram negative also grows. So if you see the growth on blood agar, you cannot say whether it is gram positive or gram negative. But when we see both the blood agar and Macon Kygo together, then we can guess. If the organism is growing on blood agar and Macon Kygo, both the agars, then we can say organism is gram negative because the gram negative can grow on blood agar and also on Macon Kygo. But if the organism is growing only on blood agar, not growing on Macon Kygo, then we can say organism is gram positive because gram positive can grow on blood agar and it will not grow on Macon Kygo. So this is the first important clue which by which we can say that the organism is gram positive or gram negative based on culture, right? Based on culture. Now, second important point. Second important point is we have to look for the morphology of the colonies, appearance of the colonies, right? Morphology of the colonies or appearance of the colonies, right? Let's take the blood agar. Now, first, I'm taking the blood agar. If you take the blood agar, so if I see the colonies, right? If I see the colonies, so this is blood agar. This is blood agar, this is also blood agar, and this is also blood agar. This is also blood agar. On blood agar, gram positive also grows, gram negative also grows. But gram positive grows only on blood agar. And when we say gram positive, so there are three possibilities: Streptococcus agalactiae, Streptococcus pneumoniae, and Listeria. Three possibilities. If it is Streptococcus agalactiae, so this is the colony of Streptococcus agalactiae, this is the colony of Streptococcus pneumoniae, and this is the colony of Listeria. So Streptococcus agalactiae shows a clear halo surrounding the colony, whereas Streptococcus pneumoniae shows greenish gray discoloration surrounding the colony. And Listeria show no changes surrounding the colony, right? No changes surrounding the colony. No changes surrounding the colony, right? So now when we see a clear halo, right? Clear halo, this is beta hemolysis. That is complete hemolysis. Complete breakdown of RBC is known as beta hemolysis. Due to complete breakdown of RBC, you can see a clear halo surrounding the colony. Such Streptococcus agalactiae causes complete hemolysis, that is beta hemolysis. You can think of Streptococcus agalactiae. Then if we talk about partial hemolysis give greenish gray color discoloration surrounding the colony. So when you see greenish gray color discoloration, you can say partial breakdown of the RBCs have occurred, and this is caused by pneumococcus. And this partial breakdown of RBC is known as alpha hemolysis, which is usually seen with pneumococcus. And the one more name of pneumococcus is Streptococcus pneumoniae. And if you see no changes, gram positive, growing only on blood agar, no changes, then that means no hemolysis. No changes means no hemolysis. Then we can think of Listeria. Right? Once again, I'm telling you, growing only on blood agar. We know that if they grow only on blood agar, gram positive. If it is gram positive, so three possibilities: agalactiae, pneumonia, and Listeria. And this is how we can differentiate them by looking at the morphology of the colonies on the culture media, that is on blood agar. Sir, when we see Macon Kygo, sir, we know that only gram negative grows on Macon Kygo because Macon Kygo contains bile salts. Bile salts inhibit gram positive, right? Only gram negative. When we think of gram negative, sir, only four possibilities. One is meningococcus. The next three are Escherichia coli, Klebsiella pneumoniae, and Haemophilus influenzae. The four possibilities on Macon Kygo. And we all know that on Macon Kygo, the bacteria which ferments the lactose sugar, Those are known as lactose fermenters, and they give pink color colonies. And the bacteria which will not ferment lactose, those are known as non-lactose fermenters, and they give pale color colonies. Right? Non-lactose fermenters, and they give pale color colonies. And there are few gram-negative bacteria, right, which will not grow. Right? There are few gram-negative bacteria which will not grow, no growth on Macon Kygo. Which will not grow or they grow very poorly. No growth or poor growth is seen on Macon Kygo. So three possibilities. So there are few gram-negative bacilli which will grow on Macon Kygo. If they grow on Macon Kygo, the colonies may be either pink color or pale color. If it is pink color colonies, those are lactose fermenter bacteria. If it is pale color colonies, those are non-lactose fermenter bacteria. And there are few gram-negative bacteria which may grow or poorly grows on Macon Kygo. So now if you see pink color colonies, so two possibilities, Escherichia coli and Klebsiella pneumoniae. Right? Escherichia coli and Klebsiella pneumoniae. So there are only three bacteria which are lactose fermenters. One is Escherichia coli, second is Klebsiella pneumoniae, third is Enterobacter. There are only three bacteria. Out of these three, two lactose fermenters, they can cause meningitis, that is E. coli and Klebsiella pneumoniae. So if you see pink color colonies on Macon Kygo, we can think of only two bacteria, sir, E. coli and Klebsiella pneumoniae. Now when we see the colonies, sir, if the colonies are flat pink color colonies, we can think of E. coli, right? High chances of E. coli. And if we see mucoid pink color colonies, then we can think of Klebsiella. So these are the clues which will help us to identify these organisms, right? E. coli and Klebsiella. The non-lactose fermenters are pale color colonies, right? Now E. coli, Klebsiella is over. Now remaining is Meningococcus and Haemophilus influenzae. So Meningococcus and Haemophilus influenzae, they come here because Meningococcus poorly grows on Macon Kygo, or sometimes it will not grow. Now Haemophilus influenza, it will not grow on Macon Kygo. No growth on Macon Kygo. Now when I say Meningococcus poorly grows, if it grows, what type of colonies are lactose fermenter or non-lactose fermenter? Non-lactose fermenter. Right? Poorly grows. Meningococci poorly grows, or sometimes it will not grow, whereas Haemophilus influenzae, it will not grow on Macon Kygo. So based on this, we can think of organism by looking at the morphology of the colonies on Macon Kygo. So this is the second important point in culture which help us to identify what is the causative agent. Right? First is in the culture, if the organism is growing only on blood agar, gram positive. If it is growing both on blood agar and Macon Kygo, gram negative. This is the first clue in culture. Second clue is based on the morphology or appearance of the colonies on blood agar and Macon Kygo, which help us to identify the organism. Right? The third important point. Right? The third important point in culture is the selective media. Selective media. Selective media. Okay. Usually Streptococcus agalactiae, there is no selective media. Streptococcus pneumoniae, there is no selective media. Streptococcus agalactiae and Streptococcus pneumoniae, there is no selective media. Usually we grow them on the blood agar, but sometimes Streptococcus can be grown on crystal violet blood agar, and we can say crystal violet blood agar can be the selective media for Streptococcus agalactiae. But if you talk about important selective media, the important selective media, you can say Palcum agar. If the organism grows on Palcum agar, then you can say the organism is Listeria, because Palcum agar is the selective media for Listeria. Listeria, Palcum agar. So this is about gram positive. Another two gram positive, like I said, Streptococcus agalactiae and Streptococcus pneumococcus, there is no selective media. Sometimes crystal violet blood agar, if you add crystal violet to the blood agar, it may act selective to Streptococcus, but still Important selective media among gram-positive is for Listeria, Palcum, agar. If you talk about gram-negative, sir, E. coli, Klebsiella, again there is no selective media. E. coli and Klebsiella, there is no selective media. We grow on blood agar and Macon Kygo agar. But the selective media for meningococcus is, sir, Thayer-Martin medium. Thayer-Martin medium, or we can use modified New York medium. These are the two selective media for Neisseria, that is Neisseria meningitis, that is meningococcus. And the third important selective media is, sir, Field's digest agar. That is for Haemophilus, Field's digest agar. This is the selective media for Haemophilus influenza. The three important selective media we need to know. If the organism is growing on Palcum agar, then you can say it is Listeria because it is selective to Listeria. If it is growing on Thayer-Martin medium or modified New York medium, you can say it is meningococcus. Right? Among the, if the patient is suffering from meningitis, then only clinically we have diagnosed meningitis. Then in the laboratory, if you see these kind of organism, this kind of growth, you can suspect these kind of organisms. Right? Field's digest agar is selective to Haemophilus influenza. This is the third clue on culture. And the last important point on culture is that if the organism is not growing on blood agar, right? So we are, like I said, all the organisms we put the sample on blood agar and Macon Kygo for all the bacterial diseases, and most of the bacteria they grow on blood agar. Like I said, gram positive, gram negative, all of them they grow on blood agar. There are few bacteria which will not grow on blood agar. Among those, one bacteria which will not grow on blood agar is Haemophilus. So if we won't see, then Haemophilus, like I said, Haemophilus, it will not grow on Macon Kygo, that I have already told, and Haemophilus influenza, it will not grow on blood agar also. That is what you have to remember. It will not grow on blood agar. No growth on blood agar, and there is no growth on Macon Kygo. Haemophilus influenza, it will not grow on blood agar, and also it will not grow on Macon Kygo. So in the sample, if you see in the microscopy, in the sample microscopy, if you see the gram-negative cocci, gram-negative cocobacilli, and if there is no growth on blood agar and Macon Kygo, then you can think of Haemophilus influenzae. So then how to culture Haemophilus influenzae? So Haemophilus influenzae grows on chocolate agar. Haemophilus influenzae. If you take chocolate agar, we know that chocolate agar is brown in color. If you take chocolate agar, on the chocolate agar, if we see the colonies, right? On the chocolate agar, if we see the colonies, so chocolate agar I will write Ca. Chocolate agar, if you see the colonies, it is Haemophilus influenzae. Whereas blood agar, which contains blood, which is red in color, if we see this is blood agar, I will write Ba. Right? If we see no growth, then we can think of Haemophilus influenzae. There is one more important point. When we suspect Haemophilus influenza, we demonstrate one property of Haemophilus influenzae, that is satellitism. Sir, what do you mean by satellitism? Like I said, Haemophilus, it will not grow on blood agar. And now if you ask me, sir, why Haemophilus will not grow on blood agar, why Haemophilus will grow on chocolate agar? So in the blood agar, factor V is intracellular. Factor V is intracellular, which is present within the RBC. And factor X is extracellular. Factor X is extracellular, which is present outside the RBC. Right? Inside the RBC and outside the RBC. Intracellular and extracellular. Factor A and factor X. Whereas in chocolate agar, the difference between blood agar and chocolate agar, in the blood agar RBCs are present, whereas in chocolate agar RBCs are lysed. RBCs are not there because RBCs are lysed. When RBCs are lysed, there is a pigment which is released, hemozoin, which gives the brown color to the media. That's why it is known as chocolate agar. So when RBCs are lysed, right, factor V is released outside. Then factor V and factor X, both are extracellular, both are present outside the RBC because RBCs are lysed. So in chocolate agar, both are available. In chocolate agar, both are available for the bacteria if the bacteria grows on chocolate agar. If the bacteria grows on blood agar, Sir, only factor X is available. Factor V is not available on blood agar, though it is present. Why it is not available? Because it is present within the RBC, because it is intracellular. Now, our Haemophilus influenza is a bacteria which requires both factor X and factor V. Both factor V and factor X for its growth. Haemophilus is a serious bacteria which requires both factor V and factor X for its growth. If there is no factor V or factor X, Haemophilus influenza will not grow. Right? So that's why Haemophilus influenza is not growing on blood agar, because on blood agar factor X is available, factor V is not available because factor V is present within the RBC. But on chocolate agar, as the RBCs are lysed, factor V is outside. Now both factor V and factor X are available. Therefore, Haemophilus influenza can grow on chocolate agar. Right? Now I said there is one property of Haemophilus influenza which we can demonstrate on blood agar. So that property is known as satellitism. So what is satellitism? In simple words, satellitism is nothing but growing Haemophilus influenza on blood agar. If you grow Haemophilus influenza on blood agar, that is what we call it as satellitism. So just now you said Haemophilus influenza will not grow on blood agar. Yes, I said Haemophilus influenza will not grow on blood agar. But why it will not grow? Because factor B is in the RBC. Within the RBC, it is not available. It is not outside. Then if you make the factor B, to come out of the RBC, then 100% now factor V, factor X both are available and Haemophilus influenza can grow. Now how we have to bring this factor V outside the RBC, that is what is important. So what we do is, so we streak Staphylococcus, that is one more bacteria, right? Gram positive cocci, Staphylococcus aureus, right? We streak Staphylococcus aureus in a straight line on blood agar. When we streak the Staphylococcus aureus, the Staphylococcus aureus will grow. Okay, fine. Then perpendicular to the Staphylococcus aureus, now we are streaking Haemophilus influenza, and then we are incubating the plate. So next day what will happen? The Staphylococcus will grow as colonies in the straight line, right? The Staphylococcus aureus will grow as colonies, and Staphylococcus produces hemolysin, a toxin, hemolysin. And hemolysin causes hemolysis, that is breakdown of the RBC. And Staphylococcus produces beta hemolysis, that is complete hemolysis. And you know that complete hemolysis, it is present as a clear halo surrounding the colonies. So this is the clear halo surrounding the colonies by Staphylococcus due to the production of a toxin hemolysin, which causes the hemolysis, that is beta hemolysis, complete hemolysis of the RBC. So you can see a clear halo surrounding the Staphylococcus. Now Haemophilus influenza B, they will start, so they grow very well near to the Staphylococcus aureus. They grow very well near to the Staphylococcus aureus. As they move away from the Staphylococcus aureus, the growth decreases, the colony size decreases, and ultimately away from Staphylococcus aureus, it will not grow. So this property is known as satellitism. Haemophilus influenza can grow near to the Staphylococcus aureus. As it go away from the Staphylococcus aureus, the growth will decrease and finally inhibited. So this is what is known as satellitism. And why Haemophilus influenza B is growing near Staphylococcus aureus? So Staphylococcus aureus producing a toxin hemolysin, which causes the breakdown of RBC, that is hemolysis. When there is hemolysis, breakdown of the RBC, factor V is outside. So near to the Staphylococcus, where there is hemolysis, factor V is outside. That means factor V and factor X both are available. That's why they are growing better. So when they are going away from the Staphylococcus aureus, hemolysis is decreased. As hemolysis is decreased, factor V availability is decreased. Therefore, the colony size decreases, growth decreases. Ultimately, when it is far away, there is no growth. So this is what is known as satellitism. Hope you have understood. If you see satellitism, then it will tell us that the causative agent is Haemophilus influenza. So these are the important points, right? In culture, by which we can say this is the organism which is causing meningitis. So this is about the culture. So CSF analysis over, microscopic findings over, culture findings over, and ultimately, sir, biochemical reactions, right? Biochemical reactions. So I'm not going to discuss all the biochemical reactions, but there are a few important biochemical reactions which are needed for our entrance examination. So what are those? For example, if you talk about The first bacteria, gram-positive bacteria, the Streptococcus agalactiae. So Streptococcus agalactiae produces CAMP factor. So detecting this CAMP factor is known as CAMP test. If CAMP test is positive, then you can say, right, if CAMP test is positive, then you can say it is Streptococcus agalactiae or group B Streptococcus. Second is Streptococcus pneumoniae, that is pneumococcus. So for that we can perform optochin sensitivity. So optochin is a drug. We have to see whether optochin is sensitive or resistant. If optochin is sensitive, then you can say it is Streptococcus pneumoniae. Or we can perform bile solubility. If the colony is bile soluble, then you can say the organism is Streptococcus pneumoniae. Or you can perform inulin fermentation. If the organism is an inulin fermenter, then you can say it is Streptococcus pneumoniae. One of these biochemical tests is enough. Otherwise, you can perform two or all the three can be performed. One of these three, if it is positive, then it says it is Streptococcus pneumoniae. Right? If you talk about the listeria, there is no important biochemical tests. We say there are routine biochemical tests, but important means important to entrance examination. If you talk about E. coli and Klebsiella, so normal biochemical tests. So if you talk about Haemophilus meningococcus. Sir, if you talk about meningococcus, very important. If you talk about meningococcus, sir, maltose fermentation is a very important biochemical test. Right? Meningococcus is a maltose fermenter because based on this we differentiate meningococci and gonococci. Meningococci is a maltose fermenter, whereas gonococci is a maltose non-fermenter. Then if you talk about Haemophilus influenzae, so very important test is, sir, Haemophilus influenzae is a non-fermenter. That means it will not ferment any sugar. It is a non-fermenter. It will not ferment any sugar. So this property is diagnosed or detected by a test which is known as OF test or oxidative fermentative test. Oxidative fermentative test. Fermentative test. So based on this test, we can say whether the organism is fermenter or non-fermenter. The Haemophilus influenza is a non-fermenter. So these are the few important biochemical tests which we need to know for the entrance examination related to these bacteria which causes meningitis. So Streptococcus agalactiae, CAMP positive, Streptococcus pneumoniae, optochin sensitive or bile soluble or inulin fermenter. Meningococcus is a maltose fermenter. Haemophilus influenzae is a non-fermenter. It will not ferment any sugar. Therefore, Haemophilus influenzae utilizes the sugar by a process known as oxidation. So it is an oxidizer. So this is about the biochemical findings. So if you see these tests positive, then that will help you to identify these organisms. So once we are done with these findings, the next lab diagnostic method is the molecular test. Right? Molecular methods. So molecular methods means detecting the gene. The most commonly used molecular method is PCR. So in the PCR, we can detect the specific gene. If we detect the specific gene, then we can say we can identify the specific bacteria. If this gene is present, this is the bacteria which is present. By detecting the specific gene, we can detect the bacteria. So that is molecular methods, right? What is the gene detected by which bacteria is not that important for entrance examination. If we talk about serological methods or immunological methods, so the most commonly used immunological method is ELISA. Right? Most commonly used immunological method is ELISA. So in the immunological methods, you know that we detect either antigen or antibody. We detect either antigen or antibody. So specific antigen and specific antibody is detected. That antigen is present, that is the bacteria. If this antibody is present, this is the bacteria. Right? So what is the antigen? What is the antibody detected? Not needed. Pneumococcal antigen, pneumococcus. Pneumococcal antibody, pneumococcus. Right? Very simple. Meningococcal antigen, meningococcus, meningococcal antibody, meningococcus. So specific antigen and antibody are detected. Now one more important immunological test that is known as rapid test. Rapid test is not the name of the test. Sir, all those tests which gives the result within 30 minutes, all those immunological tests which gives the result within 30 minutes are known as rapid test. And the very important test is LAT. in the diagnosis of meningitis. LAT. What is LAT? So latex agglutination test. Latex agglutination test. So in the latex agglutination test, we detect the specific capsular antibody. Very important. What do we detect? We detect the specific organism specific capsular antigen. Important. What do we detect? We detect organism specific capsular antigen, because most of the bacteria which causes meningitis are capsulated. Pneumococcus is capsulated, meningococcus is capsulated, Klebsiella is capsulated, Haemophilus influenza is capsulated. So all of these bacteria which causes meningitis in childhood, adults and elderly are capsulated. If you talk about the bacteria which causes neonatal meningitis, so group B Streptococcus, Escherichia coli and Listeria, so usually these are non-capsulated bacteria, but they are having capsulated strains. There are few strains of these bacteria which are capsulated, and most commonly the capsulated strains of these bacteria are the ones which causes meningitis in a neonate. So usually capsulated bacteria are the ones which causes meningitis in a neonate, and the capsular antigen is detected by using the latex agglutination test, which is a rapid test. Rapid test means the immunological test which gives the result within 30 minutes. Right? So these are the important lab diagnostic methods by which we can diagnose, or by which the clues which help us to identify the organism. Right? So organism. So last thing, so we are almost done with the class. Right? Last thing is treatment. So diagnosis is done. The last thing is treatment. If you talk about the treatment, right? If you talk about the treatment, so two important bacteria, right? Two important bacteria, pneumococcus and meningococcus. Pneumococcus, meningococcus. Meningococcus. Another two important bacteria are E. coli and Klebsiella. E. coli and Klebsiella. So these are the four bacteria in which third generation cephalosporins are preferred. Right? In which third generation cephalosporins are preferred to treat the disease. I'm not going to in depth of the treatment, but what is preferred to treat? So third generation cephalosporins are preferred to treat pneumococcus, meningococcus, E. coli and Klebsiella. Now, if we talk about the other bacteria, for example, sir, Haemophilus influenza, Haemophilus influenzae, and Streptococcus agalactiae, Streptococcus agalactiae, then I can say these two bacteria where penicillin is preferred to treat the bacteria. Right? Then the last bacteria which causes meningitis is Listeria, where we use penicillin, but nowadays ampicillin is preferred. Right? Ampicillin is preferred. This is about the treatment of the bacteria which causes meningitis. So we have discussed acute bacterial meningitis, right, which is known as bacterial meningitis, which is known as pyogenic meningitis. Though mycobacterial meningitis, mycobacteria is a bacteria, that is a separate topic. That is chronic bacterial meningitis or mycobacterial meningitis. So this is about today's session. Hope you have understood. Now, just last 1 minute, and after that you can ask. I will see your doubts. Whatever doubts you have, you can ask. Now, after discussing all these things, now how it will help us in the next examination? How it will help us in the next examination? First thing is, so when you see a clinical question, to answer, so we will get these are the clues which are present in the examination. So if you see neck stiffness is present in the question, if you see neck stiffness is present, Kernick sign is present, Brudzinski sign is present, then 100% now you have diagnosed. The question says that now they have diagnosed the patient in the question is suffering from meningitis. If one of these three, if all the three are present, 100% patient is suffering from meningitis. Then you have to look for the age group. If it is a neonate, then you have narrowed down to group B, that is Bell. If it is childhood, then you have to think of Haemophilus influenza. If it is adult, then you have to think of pneumococcus. So that's how you will again narrow down the diagnosis. Then if you see rashes are present with the meningitis, then 100% you can come down to meningococcus. Then that means if the answer is meningococcus 100% in the question, clinically they will mention rashes. Clinically, they will mention rashes. Now, in the question, if you see the CSF is cloudy, then you have to think of bacterial. Xanthochromic, mycobacterial. Opening pressure is very high, think of bacterial. Cells are neutrophils, think of bacterial. Glucose is drastically reduced, less than 20, then think of bacterial. Proteins are slightly elevated, think of bacterial. Right? These are the clues which helps to identify bacterial. Then if you see gram-positive cocci arranged in chains, think of Streptococcus agalactiae. Gram-positive cocci arranged in pairs, lens capsulated, think of pneumococcus. So differential motility or tumbling motility is mentioned, think of Listeria. Gram-negative cocci arranged in pairs, capsulated, facultative intracellular, think of meningococci. Then Coccobacilli, think of Haemophilus influenza. Short bacilli, think of Klebsiella pneumoniae. Long bacilli, think of E. coli. Then on culture, if they say grows only on blood agar, it will not grow on Macon Kygo agar. Think of gram-positive first. Growing both on blood agar and Macon Kygo agar, think of gram-negative. And on blood agar, if you see beta hemolysis, think of Streptococcus, and alpha hemolysis, think of pneumococcus. No hemolysis, think of Listeria. So gram-negative, if pink color colony is E. coli and Klebsiella, flat means E. coli, mucoid means Klebsiella. Right? If it is not growing or poorly growing, then you can think of meningococcus and Haemophilus influenza. So Haemophilus influenza, it will not grow on blood agar and Macon Kygo agar and both. Now in the question, if they mention Palcum agar, then 100% your answer is Listeria. If they mention Thayer-Martin medium or modified medium, right? The organism grows on Thayer-Martin or modified New York medium, then 100% your answer is meningococci. And if they say organism is growing on Fields digest agar, 100% your answer is Haemophilus influenza. And if they mention organism shows satellitism, then 100% is Haemophilus influenza. Then if they say CAM test positive, again 100% is Streptococcus agalactiae. If they say optochin sensitive bile soluble renulin fermenter, in the question 100% it is Streptococcus pneumoniae. And in the question, if they mention maltose fermenter, gram-negative cocci maltose fermenter, 100% is meningococci. And if they say gram-negative cocci non-fermenter causing meningitis, 100% it is Haemophilus influenzae. Right? Then if they mention latex agglutination test positive, then meningitis. It will say capsular antigen is detected and most of the capsulated bacteria that causes meningitis, then you can think of meningitis. And ultimately treatment is this. So these are all the clues, so which they can incorporate or which they can include in the clinical question I have included. So if they have mentioned 10 to 15 line of question, if you get in the next examination or NEET examination, so these are the points which help you to identify what is the exact answer. What is the exact answer? First, diagnosis, whether it is meningitis or encephalitis or meningoencephalitis, then how to identify the causative agent. So all the things are included. Hope you liked the lecture. Hope you enjoyed the lecture. With that, guys, now 5 to 10 minutes. If you have any doubts, you can ask me. So please upload microbiology lectures according to the new approach, system-wise approach, not organism-wise. We 2019 have been taught according to this new approach, and we would have to give next exam. Okay, nice, Surat Chaudhary. So don't worry, we'll upload the lectures system-wise very soon, maybe in this month itself, But one thing I'm telling you, so the way I like how I have taught you now, so these kind of system-wise lectures will be uploaded very soon, most probably in this month. But I'm telling you once again, if you have to study and if you have to remember, then always start reading organism-wise and then move on to the system-wise approach. Now, if you are in second year, now your internals will be based on system-wise. Yes, there is no doubt in that. You are in second year, your internals are based on system-wise. Even though you are in second year, your internals are based on system-wise. I'm telling you, because if you have attended my class, first read bacteriology, mycology, parasitology, virology, organism-wise. First you read organism-wise, then you read system-wise and give the examination. It will help you to remember for a long time. Without reading organism-wise, if you directly read system-wise, I'm telling you, you may feel, wow, the lecture is awesome, system-wise, but it is very difficult to remember. So just meningitis I have discussed. If you see just meningitis, you might feel the lecture was very good and you may remember also. But when we discuss all the diseases, it is very difficult to remember the findings of all the bacteria, virus, fungi, everything. It's very difficult to remember. So to remember for long term and very easily, I'm telling you, first read organism wise, then come to system wise. At least give one fast revision organism wise so that you can understand. Then you start reading system wise, and system wise lectures will be uploaded very soon. Any other doubt? So I don't see any doubts. If you have any doubts, I can wait for another few minutes, like 2 to 3 minutes. You can place the doubts. If you don't have any doubts, we can end our session. Okay, thank you. Thank you very much, all of you. Read well. I can say, read well, give your best. Your best. Don't waste time. Time is very precious. Remember this, don't waste time. Don't spend even a single day without reading at least something. Right? That means don't waste even a single day. Read something each and every day. You have to read something. You can't waste any day without reading anything, or you can't spend any day without reading anything. You have to read at least something, otherwise you can read how much ever you want, right? 10 hours, 15 hours, 20 hours, but at least you have to read for 2 to 3 hours or 3 to 4 hours minimum each and every day. You should not waste even a single day without reading anything. With that, guys, all the best. Read well. Good night. Thank you. Okay, I see few more doubts. So where I'm back. Sir, if possible, kindly do rabies and tetanus prophylaxis videos are very confusing. It would be helpful for this exam. Okay, I will try doing the video on rabies and tetanus prophylaxis. Sir, please confirm if Macon agar promotes or inhibits swarming. The answer is Macon agar promotes swarming. Macon agar promotes swarming because Macon agar contains NaCl, that is sodium chloride. Right? Macon agar contains sodium chloride. Sodium chloride. So Macon agar contains sodium chloride. Sodium chloride, that is electrolyte. It helps in swarming. So Macon agar promotes swarming. Okay, next. What is swarming? Swarming is the growth of bacteria in concentric circles, or the growth of bacteria spread in concentric circles. Spreading growth of bacteria in concentric circles on agar is known as swarming. Sir, how to gram stain? Sir, how to gram staining in CSF sample, which is doing in AIMS hospital? How to collect CSF sample and processing before going to gram staining? So CSF collection and processing, like I said, CSF collection is done by lumbar puncture, and then we have to take the CSF sample and just add 1 drop of CSF sample, then make a smear, dry it, then heat it to fix the smear, then add the gram stain. Very simple. So collection and processing is very simple. There is no special processing technique and all. So just we have to take the sample, add 1 drop of sample on blood agar and Macon Kygo, and add 1 drop of sample on the glass slide and dry it, then do the gram staining. So if Streptococcus pneumoniae is a positive organism in young adult, but Macon Kygo showing LF colonies can give E. coli and Pseudomonas pathogenic in adult meningitis. So if Streptococcus pneumoniae is the causative organism in young adult, okay, but Macon Kygo showing LF colony can give E. coli and Pseudomonas pathogenic in adult meningitis. Macon Kygo showing LF colony, E. coli and Pseudomonas is possible. Yes, it is possible. Streptococcus pneumoniae is the most common organism. I said Streptococcus pneumoniae is the most common organism, but E. coli is also the causative agent of meningitis. And yes, rarely Pseudomonas can also cause meningitis. So if you see LF colonies, then you have to think of only E. coli or Klebsiella. You cannot think of Streptococcus pneumoniae, you cannot think of Pseudomonas. Because Streptococcus pneumoniae being gram positive, it will not grow on Macon Kygo, and Pseudomonas produces NLF colonies, non-lactose fermenting colonies. Sir, have lots of query regarding CSF samples for gram staining procedure. Please send your WhatsApp number so I can coordinate with you. Thanks, sir. Great lecture. Okay, thank you very much, Madhusudan. So I think you can join my Telegram group. Right, you will get the if possible, I will paste the Telegram group link in this video at the end of the live session. You can join the Telegram group link. Then you can ask me the doubts, whatever you have in the Telegram group. Okay, I think those are the doubts. I think I have answered all the doubts. Can we have polymicrobial flora in CSF samples? Very rare, but possible. And we have polymicrobial flora in CSF sample, very rare but possible. If anaerobic bacteria, right? If anaerobic bacteria, if they are causing meningitis, then we can get polymicrobial flora in gram stain, right? And sometimes more than one organism may present, but very, very rare, very, very, very rare. So rarest things we have not discussed because those things are not important for the entrance. What are the things which are important for entrance we have concentrated, and what are the things which are not important we have not discussed. So your organism wise teaching is more than enough to do well in university exam too. Thanks a lot. Okay, thank you. That's what I told. Whoever thinks I will read only system wise, I'm telling you that's not a good decision. That's not a good decision. Always read organism wise, then go with the system wise. If you just read organism wise, I can assure you, if you just go through the organism wise, you can answer 90%, or you can say most of the questions you can answer, even from system wise questions. You can answer in the university exam, even though if you get the questions from system wise, you can answer with my class notes of organism wise. All the questions you can answer. I can assure you, all the questions you can answer. There is no doubt in that. With that, guys, I think those are the questions. Thank you. Thank you very much. See you people. Finally, at last, good night.